Dr. Ricardo Martinez is the chair of GlobalMed's advisory board. He is a nationally recognized expert in emergency care, prevention, and public health policy, a thought leader in the development of the inclusive trauma system and emerging integrated networks of emergency care. The following presentation is from the American Telemedicine Association's International Meeting and Exposition in San Jose, California in May 2012.
I just want to share with you a little bit about some of the policy issues and what's happening in the market space. Really, that's being done at the state and federal level and in the Institute of Medicine, and share that with you today. So, what I always look at is three things: where are we now, where we want to go, and how do we get there. So that's been a driving force in looking at where we are in emergency care. Emergency care really kind of came out in the 1970s with some famous papers, and I'll show you about that later, that really looked at the role of the emergency room in the hospital that had been transferred to become these big complex departments. The opportunity that lies ahead is really where a lot of this discussion started. So first, let me take you to the Institute of Medicine. In 2006, the Institute of Medicine came out with three major reports looking at emergency care. The main one was called Hospital-Based Emergency Care at the Breaking Point, and that's the one that you started seeing all these articles about long waiting, crowding, all these problems with people going to the emergency department. And that's just become a big discussion in our national psyche. But there was two other papers also that came out. One of them was about EMS on the far right, and one of them was about emergency care for children, which is interesting because they're not just small adults. It's a whole separate approach you need in terms of equipment, medications, everything else. And so they looked at those three areas. I'm going to focus my comments really on hospital-based emergency care. As you know, the Institute of Medicine is part of the National Academy of Sciences, and it actually is an advisor to Congress. So when these reports come out, they have fairly significant weight, and they generate a lot of legislation both at the federal and the state level, as well as a lot of policy issues. And I'll show you that actually a little bit. One of the reports is what generated the big push for healthcare IT that brings a lot of us here today. So let's just focus on the one on the left, okay? They kept talking about building a 21st century emergency care system. And the idea was it would be an integrated system of emergency care. So the question then came up was, what do you mean by integrated? Well, the recommendations were made across all the reports, and what they said was a coordinated, regionalized, and accountable emergency care system. So what happened was everybody began to pull out their old approach, which is we'll regionalize like we did for trauma. If the patient has a problem, we'll take that patient to the trauma center. If the patient has a stroke, we'll take that patient to the stroke center. If the patient has a hand injury, we'll take that patient to the hand injury. So they looked at kind of as having a federal or a state or regional entity that would look at regionalization kind of being the traffic control cop, right? The flight control. And so this is from the report itself. You can see, looking at the various specialized center and moving the patient to those centers for definitive care. There was a report that was done, a workshop followed this report in about 2008. What happened was, based on this paper here, everybody said, okay, we're the stroke people, bring everybody to us. We're the trauma people, everybody bring it to us. They went and did a regionalization workshop. And in that workshop, one of the things I was asked to do by Arthur Kellerman, who's head of Rand Corporation Health, is I disagreed with what they were doing because I thought it did not take into consideration the modern technology we have today. So what I talked about was, can we look at it differently? So I want to share with you a slide that I used to open my presentation. I had 15 minutes to try to change the winds, right? And so I said, look, have you ever been so focused that you actually don't realize what you're doing? And so the story I told was when I went to the airport, I was flying back from somewhere. I arrived at 11:30. I had to be on a conference call at 12:30 with a video conference call. It takes me half an hour to get to my house, so I had the shuttle take me to my car, and they drop me off. What they do is they give you a little piece of paper. And that little piece of paper just determines whether you're in covered or uncovered parking. That's a difference of about $3 a day, and I've been gone for 4 or 5 days, and I'm not going to pay for covered when I'm in uncovered, okay? So the lady gives me the piece of paper. I get to the back of my car, open the trunk, I throw my suitcase in, open the back door, put my coat on, get in the front seat, turn on that car, and I can't find that piece of paper. So what I was very focused about getting out of there right away. So I started looking around. I get out, and I checked my coat, and I checked my pants. Couldn't find it. Went in the back, checked my coat that was hanging in the back. Couldn't find it. Went in the back, looked in the trunk. Saw the lady with a shovel, started waving to her, because I know she must not have given me my piece of paper. She must still have my piece of paper. Started waving to her. She doesn't come. Something wrong with that. Go back, check my luggage again. Now I'm beginning to open my briefcase. So maybe I put it in my briefcase. Can't remember doing that. But I got to get home, and I got to get home in 30 minutes. And so I check my pants again, check my coat. Finally, she sees me. I'm waving to her. It's beginning to rain now. And so I think maybe it's underneath the car. I get down on my knees in the rain, get in the dirt, looking underneath. Finally, she drives up. And when she drives up, I started to yell at her and say, I need my piece of paper. And I realized where that piece of paper was. I took a picture of myself with my BlackBerry at the time. There you go. Okay? Piece of paper was in my mouth the whole time. When I went to yell at her, I realized that I had it. And so I use this to say that sometimes you get so focused on something to do what you want to do that maybe you missed the big picture. Maybe you missed the big opportunity. So the idea was, you look at regionalization. Regionalization came from the 1970s. Did you know that? It came from the 1970s. And the driving mantra, if you're a physician or a nurse or a medic, is get the right person to the right place at the right time. Get the right person to the right place at the right time. And so what happened was everybody started doing trauma systems and hand systems and things like that, where the EMS systems would now become regionalized and would call out those patients who needed that care and bring them to the specialized care. Okay? Well, it was actually designed for very low frequency things like a major trauma or a big cardiac arrest or an amputation, but high impact events. It also changed the world. It designed all the systems we have today. It led to many improvements in patient care, but it actually has not spread. A lot of places don't even want to be trauma centers. A lot of places don't want to be part of a regionalized system. So that care is not distributed to the patients very well. And what I was saying was maybe it's not working as well as we'd like. We started this 30 years ago, and we still have a very fragmented system. So if you look at EmergencyNet, which is looking at the visits in the EDs, what you actually find is that the vast majority of patients go to smaller ERs. Only the real big ones on the far right are very far and few between, but they only account for a very small amount. So the vast majority of the patients are seen in smaller facilities throughout the country. And so we really don't have a system that supports those patients or those hospitals. As a result, we put a lot of negative pressure on them. This is the current system that we have. If you look at it, we move the patients up. To give you an idea of the distribution, people who are specialists like to be the top of the food chain. They like all their equipment. They like having a lot of other specialists with it. If you look at the way it's designed, right here, 66% of your board-certified, 70% of your board-certified ER docs work up here. Only about 30% here. This is mostly family practice down in this area. Most of your specialists are up here. This is more generalist, general surgeon, internal medicine, that sort of thing. So you really have a maldistribution of resources, though the majority of the patients are outside of this environment and down here. Works the same way with your equipment and your resources. They're maldistributed. If you look at the reasons people go to the emergency department, it's not that everybody is having a stroke or having a heart attack. It turns out that really only a very small amount are that high part. The majority of patients do need to be in the ER, and only a small percentage don't need to go to the ER. So you really do have patients, the vast majority of patients who have a real problem that has to be evaluated within a 24-hour window, but not someone that you need to call out and go. So all these patients, we don't have a system that's providing them care with all the capabilities. It's only if you're in this top percent that you may get called out for specialized care. If you look at the main chief complaints that we have, abdominal pain is actually routinely every year one of the top complaints, top two complaints. Chest pain, undifferentiated, not a stroke, not a they call it ST elevation MI. We know that it's binary. We're going to bring it to the cath lab. Just plain old chest pain, okay? And then headache. If you look at these patients, they're a lot of times because we don't have the care available locally in the smaller hospitals, they're transferred up the chain. And then the question is, what happens when they transfer up the chain? So I went to the feds and I said, what happens to these people? Well, a couple things. No one tracks this, right? So you have to infer it. But they came up with a number. This came from HRSA, that 70% of those patients are discharged from the receiving facility. 70%. Well, I work at Grady Hospital in Atlanta. So I went to Grady and said, what percentage of patients are transferred to other hospitals? We discharge from the ER. Don't even admit. The answer they came up with, 70%. Went to Savannah Memorial in Savannah. They got 5 hospitals that we were referring to, asked them what percentage of the patients are transferred to the emergency department. They're discharging from the emergency department, not even admitting. And the answer was 70%. So I think it's high, but even if it's one half of that, you can see the system is leaving patients going through from a small facility to going away. What's happening to the smaller hospitals, they're dying. So we look at the economics of transfer. very hard on the patient, because patients actually go to another city, no way to get back. Over time, the families begin to bypass the local hospital because you have to have a car. So they don't even bother to go to the local hospital. You'll see little cities where the volume's going down in the hospital because the people nearby know if you got a headache, if you got chest pain, if you got a belly pain, they're just going to transfer you. You might as well go somewhere else. What does it do to local facilities? Most of these local facilities make about a 1% margin, and that's because they admit about 6% to 7% of their patients. They transfer about 7% of their patients. Those patients are discharged to the other facility, meaning they could have been kept locally. And so what does it do to the local providers? We realize over time the local providers lose their capability to take care of complex patients. And what does it do to the community? It ends up being where the community gets stressed. What are some of the other problems with this always going uphill problem? It's actually the stress in the system. When you call another facility upstream, there is no relationship normally. You're basically calling, saying you need help, as they transfer the patient. Many times they think you're doing it for financial reasons, quite frankly. Sometimes it's hard to get someone on the other side of the phone to answer. If you send somebody, there's no feedback loop. You have no idea what you sent, whether you were right or wrong. And so that's why your knowledge goes down over time. But I'll tell you, when you talk to the docs in those smaller facilities, they really hate dealing with the transfers because it's not a relationship. They're just invoking, I need your help, and the patient goes away. And they never get any feedback, and then they never see that patient again. This is the report I was mentioning back in the 1970s, came out, 1966 actually. Are y'all familiar with this report? It's called Accidental Death and Disability. Coming back from Korea, a lot of the surgeons came back and said, it's interesting that in Korea, if you're injured, we send out helicopters to get you to medical care faster than we do on the nation's roadways today. Interesting enough, this is the beginning of EMS, came out of this report. It was the application of military principles to the United States. And interesting enough, if you were a medic, you were DOT certified to begin with, because the Department of Transportation is where EMS came out of in this country. You may or may not know that. That's why NHTSA, the National Highway Traffic Safety Administration, still is one of the bigger players in EMS. Well, that was a very important report. It created these systems that we have today for EMS. You know, we say, you call, we haul, right? 911, we've got a system, everybody knows that. But the problem is that it's time to move to a bigger paradigm. In 1999, a report came out called To Err is Human from the Institute of Medicine that said we're killing a lot of people in the highways, in healthcare. Remember that? So people got a little nervous about that. And so they started saying, well, what are we paying for in healthcare? And they said, how about if we pay for quality? There's a thought. So this report came out in 2001, and this report has driven everything that's happening in this hallway and in healthcare right now. This report is called Crossing the Quality Chasm. It came out with a definition of quality with measurable endpoints for it, and I'll walk you through it. But who was on this committee? Mark Chassan, who's now the head of JACO, or the Joint Commission. Don Berwick, who became the head of CMS. And Janet Corrigan, who became the head of the National Quality Forum, driving this vision of we're going to pay for quality. It's making everything happen. So it came out with six measures. Patient-centered. Because remember, no one cared about patient satisfaction when this report came out, right? Nobody cared. Safe. All the safety issues started driving because we're not going to pay for things that aren't safe. Effective. That's why we're talking about evidence-based medicine. That's why we have core measures. Efficient. That's why we look at time to doctor, door to balloon, all these issues. Timely, same sort of thing. That's what drove stroke and cardiac programs, was the idea that we're going to have timeliness measures. And then equitable. And what's interesting is that I used to believe it was fairly equitable in some ways, but the difference was big hospitals versus small hospitals. But we're seeing it really has to do with where there's access and where there's not access, right? So all these things can be measured at the patient, the provider, and the systems level. So most healthcare systems are moving to measurable metrics. I heard some discussion about telemedicine yesterday. We don't have measures. We should. Because if I can cut the time to being seen by a neurologist from 2 hours to 13 minutes, that's a pretty impressive metric to show the value in terms of quality, right? In terms of quality. So the other thing is interesting is that they said, let's do 6 things to redesign healthcare. Re-engineer the care processes, effective use of information technologies. And with that, they put $45 billion into the system to push healthcare IT. Okay? So remember, this was a report to Congress saying you need to do this. Knowledge and skills management, so the idea of EMRs, clinical decision support, all this stuff comes out of it. Development of effective teams. And this is a little hard because physicians aren't taught to be good teammates, right? Because they're all taught to be individuals. So you see a greater focus on teamwork. Teams are safer than an individual and more effective. And the coordination of care. Again, same things you hear all the time now about coordinating, right? So what we did was we said, look, maybe the reason we haven't had uptake in regionalization after 30 years is because the model's wrong. Apple wouldn't keep trying to sell something that didn't get uptake in the market for 30 years, would it? Nobody would do that. But we keep doing that in healthcare. So what I try to tell them is not all change is bad, okay? That's my picture of me at Stanford when I was in faculty. Pretty impressive, right? But I got to tell you, even that change is an improvement over my college days, okay? All right. So what are some of the challenges? What's funny is I've done some travel with some various companies and gone to various countries, including China, and gone to Mexico and others. And I got to tell you something. These challenges are ubiquitous. They're the same in the United States, and that is time, distance, and geography is an issue, right? Especially if your quality metrics are safety, efficiency, patient-centeredness, those sort of things. Restricted access to information. I was telling Steve Forbes with HCA here. I was telling Steve what changed my career was the invention of the fax machine. Because in the ER, I could get a copy of that old EKG, and I could never get that before. So access to information in an industry that's so information intense, it's in little boxes. And the ability to make those decisions is based upon the quality of information I have. We have workforce shortages. We talked about the maldistribution. But we also have an aging population that are more complex. The average Medicare patient now has 5 physicians. Did you know that? 5. And if they have CHF and diabetes, they have 13. So how do you manage all that? Aging population and the growth of chronic diseases. If you look at the healthcare debates we had, the vast majority of that discussion was about chronic disease, longitudinal care. Very little discussion about acute care. We talked about not being left in. We were kind of homeless in the healthcare debate, right? And emergency care. Access to primary care is limited, even if we wanted to get more people there. The maldistribution and the ability to get primary care is going to be limited. And so what we see is that there's opportunities though. We do have a lot of resources. We have technology that can leverage our ability to scale cognitive resources. Everything's moving electronic. So as EMRs come in, we're seeing a rapid translation into information. In fact, I see patients at Grady Hospital, which is one of the old great hospitals, 117 beds in the ER. Only in the last 2 years have I converted from paper to electronic. And that was a painful process, but I'll tell you my process before. If I needed to write in the patient's chart, I looked on the board to see which resident had that patient. I would find that resident in his white coat. They would have the papers filed. I would look through the papers, pull it out, write my note, put it back in the file, and that's how I did it. Now I can grab any computer anywhere, make my decisions on the patients. But now the biggest problem we have is almost too much information. I'll have patients with hundreds of visits. So that has been a huge transition just in the last few years. Growth of the ability to share that information with high-speed networks. And I like this. The move toward quality and value-based payments is actually beginning to put metrics in place that we can use to enhance our performance. And then I think the development of health information exchanges, whether they're done through government or through private sector, is going to actually rapidly improve our ability to take care of patients across facilities and across regions. That's a huge opportunity. So let's look at the world of patients. If the technology and the equipment is fixed, like a cath lab, then we have to move the patient there. If the procedural skill is fixed, because now remember, procedures are very different. If the procedural skills are fixed, like a laparoscopic or a STEMI protocol, something like that, that's fixed. But if it's cognitive skills, we can move that to the patient, right? So what we want to be able to do is be able to redesign so we can collaborate. The focus of the words you keep seeing, going back to the IOM report, it's all about integration and collaboration. So now I can take that information and I can move it to the patient. These slides are from several years ago. Look how much it's changed. These were all the areas that we felt that you could make a difference. These are all the areas you're now seeing out in the real world. But I want you to understand that as we move information back the other direction, this is really what I think is fascinating, is that you're beginning to see the people at the downside of the healthcare system becoming more capable because they have feedback and continuous training from those who are the specialists up above. And so if you look at when they put a stroke system in place, you'll see that the number of calls is very high. Then it goes down as people get better capabilities to take care of that. We look at the attributes of healthcare healthcare, going back to remind you what they were: patient-centered, safe, effective, efficient, and timely. You can see that we can now apply that to a system. So let's look at the changes that we're doing. The driving system developed in the 1970s was get the right patient for the right place at the right time. Now the mantra, and this all occurred about 2009, 2010, you're going to see this more and more in the literature, more and more at the federal level, and more at the state level, is get the right resource to the right patient at the right place at the right time. And at the right place becomes the critical change in this. We no longer have to always talk about moving the patient. We can talk about moving the information down there. If you look at it, that's starting with the very discrete things, such as stroke, and where I can move the images and do that, but you're going to see that expand dramatically. So now this area of going up, we're now going from abundant care and provider needs to patient needs. We're going to flip that now, flip it so it goes both directions. And what we're seeing is that these smaller facilities have a much greater interest now in participating in telemedicine because it allows them to maintain the patients and financially make them more viable but not training. And these groups up here, believe it or not, are actually more interested because they can expand their skills, but at the same time they can decrease transfers that are unnecessary they don't get paid for. So the win-win for all of them. We're beginning to see a lot of these areas in the marketplace now in various stages of development. Interesting enough, psychiatry is one of the ones that we see a lot of people very interested in because it makes it very hard for them to make a disposition on a patient without that specialized care. And yet we all know that there's very little procedural issues in psychiatry. It's almost all cognitive. So you're seeing a much greater demand for that right now. And we're also seeing the growth of telemedicine, emergency medicine, giving emergency medicine only. In Mississippi, Jackson, the program in Jackson actually trains nurse practitioners now, and they train the nurses. The nurses go out and run ERs by themselves. They have a ER physician on doing a teleshift at the main hub in Jackson, so he may be covering 5 different hospitals. And so that's become a very successful model because it's much more cost effective, but the overall issue is the quality of care cannot be diminished, right? Cannot be diminished. So we see a large growth in the ability to take information and make it mobile. And we started by saying, look, don't try to do what we always do. Don't try to have a state regionalization program. When we had these debates, the thing I found interesting, all the state EMS directors wanted to run this because they thought they needed to control this. That's what they did for trauma systems, burn systems, everything else, very effectively. But we felt that the market's not ready to build this from the top down. You need to let the market itself do it and build from the bottom up. Usually with organizations doing it within their network and extending it to people outside the network. And what you're seeing now in the marketplace is a big push toward affiliations. Affiliations either on a particular discrete issue or affiliations for a suite of services. So what we mentioned is that, there are the winds of change. We're seeing a lot more groups come into it. Just look around the exhibit hall and see how many more groups are involved. It's both federal and state and private sector, which we think is making things come together faster. You may or may not have seen that Team Health just announced a relationship with Specialist on Call. Team Health has over 300 emergency departments around the country. Part of the reason they're doing that is to deliver services across a suite of services rather than just a discrete issue. These are things that I think you're fairly familiar with, right? All the things that are coming down the pike. I'll tell you this, my view of the marketplace is that while you may be very smart about telemedicine, you may be very familiar with telemedicine, people on the clinical side are just beginning to wake up to it. I know some of my IT colleagues have been pushing this for quite a while, but beginning to see that there's little small areas where people are smart about it. But I was taught by a mentor that said, keep saying the same thing till you're sick and tired of saying it. And when you're sick and tired of saying it, you can't say it again. You're just beginning to hear it. It's about a 3 to 5 year cycle. And I think for telemedicine, you're beginning to see, because some discrete models were done, you're beginning to see greater ideas and innovation coming in the marketplace. I think for all of us in the next 18 months, you're going to see a much bigger push for this kind of connectivity for a suite of services rather than just one. A couple of the things that are occurring, we looked at what do you got to do to help change things. Number one, you got to categorize emergency departments and patients and resources based upon what the needs are and the capabilities, so you can begin to match that and you can begin to measure that. We wanted to change the driving goal of regionalization from top down to bottom up and then match the resources and needs. And there's actually a lot of work being done on this, including the fact that the National Quality Forum, I don't know if you know the National Quality Forum, but all those core measures out there, the national specialties come together they make up measures. They send that to the National Quality Forum, which then puts an expert panel together that says, are these good measures or not? Are they valid? Once those are considered valid, they then submit those to CMS for possible use. So anytime somebody says, oh, these stupid core measures, these stupid metrics for Medicare, the government's trying to tell me how to practice, has to realize we wrote those. As the specialists write that, submit it for validation, then it goes up. And so you see a lot of push right now to develop measures that grow across not only the patients, but on the system side. So the other issue we talked about, do the greatest good for the greatest number of patients. Quit just worrying about the small STEMI patients or the stroke patients. Do more. Drive value through measurable quality for a system. Do no harm to others. Right now, the only people who do well are the ones at the top of the food chain. The ones at the bottom basically have little resources. And then make sure that we work to redesign these markets. So what's happened so far? These concepts have come out, and there's a annual meeting right now from the Institute of Medicine. These concepts are being put into the professional associations, but what you're beginning to see is some change now as people come to the marketplace. I mention all this because I think the time is right for many organizations to begin to embrace telemedicine in different ways rather than just stroke. And you actually have the opportunity to do greater good to a greater number of patients who are currently outside the system because of lack of access. So the growth of telestroke and other services is now increasing rapidly. More telemedicine models in the market. I mentioned the growth of places going to use mid-levels with physician oversight to do generalized primary care, essentially, or emergency care throughout the marketplace. I think it's North Dakota has what they call the pioneer hospitals, where they have 1 or 2 patients a day, seen by the nurses there, call in for an emergency medicine consult. So we're beginning to see uptake in the market because there's need. The National Quality Forum is coming out with measures for the development of the system, measuring quality within a system for transfers, and looking at cost also. You know, the OIG opinion that basically says that you can give equipment to some places in order to help support them and not be in conflict with stark issues. We're looking at just expansion, huge expansion of wireless networks and mobile devices. And then last year, for the first time, the American College of Emergency Physicians formed a telemedicine section. And in that, what you found is that people who are getting the equipment for telestroke, they used it for all kinds of other things because they have a need, right? Like teaching nurses on one end of the phone, the system, back at the other end, how to care for a certain kind of equipment. They don't transfer the patient for being too complex. Again, going back to the issue of education and training, developing an ecosystem that everybody wins in. More states requiring payment for telemedicine. I think that's an important issue being looked at by ATA and others. But it is provision of care. It's usually more cost effective. There's usually total cost that's less overall when you look at transfers and everything else. CMS rule that allows reciprocity and credentialing. And lastly, the awakening of healthcare providers and consumers. A lot of people have been concerned that will consumers accept telemedicine programs. And what we're finding is that they accept it very well because now we're saying to the patients, we're not going to send you to the doctor's going to come here to take care of you. And so with that, I just make the last point, we see huge transitions occurring in emergency care right now. Most of these professional organizations are just beginning to wake up to the opportunities they have to do a better job of caring for their patients. But I'm a big believer in Peter Drucker's comments that you can predict the future. You absolutely can. And the best way to predict the future is to create it. And with that, I want to thank you for all the work you've been doing, and I'll be happy to answer any questions if anybody has. Thank you.